to note on a very timely basis that on Tuesday this week, it was announced that the United Health Group has agreed to buy LHC Group for over $5 billion. And LHC is one of the country's largest home health firms. In announcing that acquisition, United Health said that the trend toward home-based care is just beginning, and they would United Health would provide more access to care at home in a lower cost setting than nursing homes or more advanced care facilities. Humana, by the way, similarly purchased Kindred at Home last year and says they are now the largest home health provider in the US. Overall spending for home health care last year was about $122 billion and is expected to reach about $230 billion by 2030. That's an annual growth rate of close to 77%. And according to CMS's annual report, which was just issued earlier this week on national healthcare expenditure. This is a big deal, and one we will continue to monitor in our ongoing work. Finally, on behalf of BPC, I extend thanks to the SCAN Foundation for their support of today's event and BPC's new policy roadmap report. I should quickly add, since I've mentioned him, that neither United or Humana have supported any of this work that BPC has been doing on this area. Now I would like to turn it over to the president and CEO of the SCAN Foundation, Dr. Sharia Mohanty, for her opening remarks. Doctor, over to you.
Thank you very much, Bill. It's really a pleasure to be here. And I would also like to thank the BPC team, specifically Lisa Harutunian and Cameron Perry. You know, this report released today offers some real concrete solutions to advance efforts that improve and expand the availability of medical and non-medical services, including long-term services and supports, and even services that address the social determinants of health, such as food insecurity for people with complex needs. This report also highlights the importance of creating, as Bill mentioned, very streamlined, simplified, and integrated care available in every state. The policy roadmap includes key recommendations being actively reviewed by policymakers and helping to guide the field. Just last week, the Senate Aging Committee held a hearing that highlighted recommendations included in this report, specifically, again, about streamlining and, in essence, modernizing home and community-based services. As we all know, people with complex health and social needs continue to face both disparities and inequities related to systemic bias and discrimination based on race, disability, income status, sexual orientation, gender identity, and other characteristics that are commonly linked to being marginalized. Health systems, providers, payers, policymakers increasingly are recognizing the need to advance health equity for people with complex needs and help them thrive. There are a few recommendations that improve access to care and quality of services and take action to advance what we describe as person-centered equitable care. BPC recommends multiple ways to improve access to home and community-based services, or HCBS, within Medicaid for low-income individuals, and creating a buy-in option for those with middle or higher incomes. And this will be, for example, especially important for the category of middle-income Medicare-only recipients ineligible for Medicaid, sometimes deemed the forgotten middle, those with the fewest HCBS, long-term care, and long-term services and supports options to pay for their care needed as they age. More than 1 in 5 Americans, 21.3%, are family caregivers, having provided care to an adult or child with special needs at some time in the past 12 months. And BPC's report also recommends providing assistance to these unpaid caregivers, who often give not only personal assistance, but also financial support to their loved ones. As individuals, families, and communities are still living with the COVID-19 pandemic, we are reminded how important family caregivers are in American society. The report also references important work being done on the temporary Medicare and Medicaid flexibilities enacted in response to the COVID-19 pandemic to ensure people could maintain access to the care and services they needed. Collectively, the policy roadmap outlines numerous ways we can make our systems of care, especially long-term care, more equitable, person-centered, and community-centered. I am proud to say the SCAN Foundation has been thrilled to work with BPC since 2013. This policy roadmap represents a body of work we, as well as others in the philanthropic community, have supported. In closing, I want to recognize those partners, including Arnold Ventures, the Gordon and Betty Moore Foundation, and the Robert Wood Johnson Foundation. I will now turn it back to Lisa with BPC for the panel discussion. Thank you very much.
Thank you, Dr. Mohanty, and thank you to everyone tuning in today. My name is Lisa Haratunian, and I'm an Associate Director for the Health Project at BPC. Today, I'm joined by 4 panelists, and together they will bring a range of perspectives and valuable expertise to our discussion on improving care for those with complex needs. As we begin the panel discussion, I will first introduce each of our speakers, and then we'll dive into some questions. Our panelists will highlight challenges around accessing care, particularly around access to LTSS and integrated care. Then we'll talk about some federal policy solutions to address those challenges. Toward the end of the panel discussion, we will respond to some audience questions. So we encourage all of our viewers to submit their own questions throughout the panel discussion using live chat on YouTube or on Twitter by using #BPCLive. Now, the first panelist I would like to introduce and welcome is Pamela Parker. Pamela is currently a Medicare Medicaid integration consultant at SNP Alliance. Pamela has over 34 years of experience in state government in Minnesota, and she was also responsible for the creation of the first CMS-approved state Medicare Medicaid integration demonstration for people with dual eligibility. Next, I would like to welcome Henry Claypool. Henry is the Policy Director at the Community Living Policy Center at Brandeis University and a consultant with BPC. He is also a former director of the Health and Human Services Office on Disability and a founding principal deputy administrator of the Administration for Community Living. Next, I would like to welcome Bea Rector. Bea is the Director of the Home and Community Services Division within the Aging and Long-Term Support Administration in Washington State's Department of Social and Health Services. Bea has worked in long-term services and supports at the state level for 20 years. And finally, I would like to welcome Dr. Mark Cohen. Dr. Cohen is a professor of gerontology at UMass Boston's Graduate School of Policy and Global Studies. He is also the co-director of the Leading Age LTSS Center. Dr. Cohen has a long history of research on long-term care service topics, and throughout his over 25-year career, he has testified in front of Congress and has often spoken as an expert on long-term care. So big thank you to each of our panelists for joining us today to talk about improving care for individuals with complex needs. This heterogeneous population may include individuals of all income levels with functional limitations or cognitive impairment, multiple chronic conditions, or a range of medical and social needs, including long-term services and support needs. And individuals with complex needs who may require assistance with personal care, but who prefer to remain in their homes or communities, often experience challenges accessing those critical services. And also with a rapidly aging US population and the risk of COVID-19 infection and mortality in congregate care settings, the need to improve access to Hcbs has received national attention. So let's talk about what these types of services mean for beneficiaries, current barriers to accessing care, and some policy solutions. So Henry, this first question is for you. Would you please talk about why access to Hcbs is important for beneficiaries and what impact these services have on individuals' ability to live independently and to work?
Sure, thanks, Lisa. Just quickly for background, we need to bear in mind that older adults and people with physical disabilities really rely on this assistance with dressing and bathing and transferring. People with intellectual disabilities really need some support, perhaps queuing during the day, so that they can get those activities done and lead a meaningful life. And finally, there are people with mental health issues that might need help with their medication and benefit from peer support as they move towards recovery. Getting these needs met is really essential for these populations to pursue the goals of the Americans with Disabilities Act, like independent living, greater economic self-sufficiency, et cetera. And for older adults, people want to remain in their homes, even as they need assistance with these activities of daily living. One other real benefit to offering more Hcbs is that it allows states to fulfill some of their homestead obligations, a civil rights requirement. But finally, we have some of the challenges that underpin this. And that is, unfortunately, we're looking at a shortage of direct care workers, often due to the low wages that they're paid. In addition, people that are enrolled in these programs across states the states have set limits on access to Hcbs, sometimes in the form of waiting lists. Fortunately, there may be some action on the Hill this year where the Senate is considering a modest investment, perhaps in Hcbs. We look forward to learning more about their legislative actions in the Senate to improve access to Hcbs.
Excellent point. Now that we understand the importance of these services and some of the barriers to beneficiaries accessing them, let's talk about barriers to their delivery at the state level. So this next question is for B. States have, on average, 5 1915C Hcbs waivers, and some states use up to 11 waivers at once to target Hcbs to different subpopulations or regions. What types of administrative challenges do states experience in providing Hcbs through this pretty complicated patchwork of Hcbs waivers and state plan amendments?
Yeah, thank you, Lisa. You know, we are one of those states that uses 11 different Medicaid authorities to deliver home and community-based services. And I think it's helpful to provide a bit of context as to why this has been necessary for states. States share in the goals that Henry talked about, assisting individuals to access and receive services that support them in living outside of institutional settings. People do want to be in their own homes and community where they can exercise choice, independence, and autonomy over daily living decisions. And creating systems where that is supported makes sense for states and the federal government too, because people have better quality of life, and on average, it's more cost effective than serving people in 24/7 settings. However, we need to do that in the context of working within the budget authority we're given from our state authorizing environments. In other words, we need budget predictability, or if we don't have that, we risk cutting services and creating wait lists. And as Henry noted, lots of states do have wait lists. To manage budgets, we use a variety of Hcbs authorities so that we can tailor and target benefit packages and levels and types of services to the different populations that Henry described. You know, some individuals have intensive, high need, high cost services with specialty providers, and others may only need a few hours a week of a non-medical services to meet their health and wellness needs. We also need those variety of authorities to be able to serve individuals with higher incomes, but who still need the assistance of Medicaid to pay for services. And we also need them to support particular delivery models such as managed care or fee-for-service or financial management agencies to support the large self-directed workforce of paid family and friends in Hcbs. However, these policy goals and the federal authorities we have at our disposal to meet them have created an extremely complex set of back office functions, as each authority has different requirements, different service definitions, rate methodologies, billing and account coding, and reporting requirements. 1915Cs, which represent a majority of the authorities used in states, must be renewed every 5 years. We just submitted renewals for a group of waivers that support individuals with developmental disabilities in our state, and it involved over 1,200 pages of application, countless hours of preparing evidence reports, documenting rate methodologies, defining services and provider types. And this is needed whether the waiver is brand new or whether it's been in place for decades. And in fact, we have one of the oldest waivers in our state. It's been in use for 40 years and it still has to be renewed every 5 years. We have limited administrative staff because we really strive to put as many dollars as we can into direct service delivery and oversight of the services being provided. So the complexity of authorities' taxes are limited resources and pulls us away from activities that would be a higher value add for the people we serve. And finally, I'll just say this has been made worse by the pandemic and the number of emergency authorities that we're managing to support the health and safety of clients and their providers, as well as shoring up fragile provider networks. Unfortunately, the complexity is not limited to our back office functions and staff. These complexities are also experienced by the case managers and the options counselors that work directly with individuals who need access to the services, as well as their families and their support systems. That's really the problem we're trying to solve.
Great. Thank you so much for providing those excellent examples of those administrative challenges that states are really facing. Let's talk now about some of the challenges that beneficiaries who are dually eligible for both Medicare and Medicaid experience. Pam, this next question is for you. So full benefit dual eligible beneficiaries receive both Medicare and Medicaid, which include Hcbs to some degree in all states. And only about 10% of dual eligible individuals, however, are enrolled in integrated care models. What types of challenges do dual eligible beneficiaries experience in accessing their full range of benefits when they are in non-integrated care models or lack access to those fully integrated care models, such as a fully integrated DSNP, PACE, or some other integrated health home type model like Washington State's model?
Thank you, Lisa. Yeah, despite working over the past 25 years, as many have, to develop integrated care delivery options for the dually eligible people, about 90% of them don't have access to any kind of integrated care system as you're outlining there. And on top of having to deal with all of the multiple complex medical conditions and social health needs that people with dual eligibility have, the majority of them also have the burden of having to navigate 3 or 4 different eligibility, payment, and service delivery systems in order to access all of their needed benefits. Providers serving this population then also face competing and unaligned financial and clinical incentives that impair the coordination of care and result in cost shifting and inefficiencies between payers. The current system is just very fragmented, uncoordinated, inefficient, and complicated. Just an example, dual eligible individuals typically have to present multiple eligibility and enrollment ID cards to access medical or pharmacy services. So those in original Medicare, which is a fee-for-service program, have to have a card for Medicare A and B and a second one for Part D pharmacy plan benefits, plus a third card for Medicaid. And if they're enrolled in a Medicaid managed care plan, they also may need another card for that plan besides their regular Medicaid card. So they could be using up to 4 different cards, and there are scenarios that are out there that where even more cards are required. In addition to that, then nearly 40% of dually eligible individuals have enrolled in a Medicare Advantage plan, often because those plans provide critical supplemental benefits such as hearing, dental, and vision care, which are often not included in Medicaid, but they are enrolled in that plan only to find that they're also have chosen a Medicare plan that is not associated with their assigned Medicaid plan in the states where there's a lot of Medicaid managed care going on. And now they're in a situation where both plans may have their own separate care coordinators, assessment systems, separate networks, and they don't necessarily work together, which further exacerbates this clinical and financial conflict for providers who are operating under those unrelated plans in order to provide services to the dually eligible. And then we've got the problem with advocacy and education systems for coordinating Medicare choices with Medicaid are very spotty across the country. And this places the burden on the dually eligible person or their family to try to remember the names of who does what and what part of the system do they come from. And they have to keep track of separate enrollment numbers, separate customer service telephone numbers. They have to follow different coverage, authorization, payment, and appeals and grievance rules, and attempt to understand hundreds of pages of separate and very confusing, conflicting, and duplicative materials that come from all these different sources. And then some services like durable medical equipment and home health may overlap and be somewhat covered by Medicaid and somewhat covered by Medicare. And it's really like rocket science to have to understand all of these details. It takes a huge amount of time and energy that many people with chronic health needs just don't have. And yet what I'm describing is very typical for the vast majority of people with dual eligibility. What's not typical and should be more typical is that they are enrolled in one plan or parent entity responsible to align clinical and financial responsibilities for coordination and delivery and payment for all services across the whole spectrum of preventive, primary, acute, behavioral health, and home and community-based services. And that is the vision of BPC's recommendations for integrated care that they have outlined in this report.
Thanks, Pam. Great point. And so now we've talked a bit about those barriers to care for both Medicaid and the dually eligible beneficiaries. But another really important population is the population of those with complex needs who do not qualify for Medicaid-covered LTSS. So this next question is for Dr. Cohen. Medicaid is the predominant payer for LTSS, including Hcbs, but it's a program only available to individuals that meet the low income requirement. What barriers do middle and higher income individuals experience in accessing affordable services that allow them to age in place?
Thanks so much, Lisa. First, let's start with the proposition. These services cost a lot of money. The average lifetime expenditure before death for individuals turning age 65 is close to $140,000. And if you have to purchase care, public and private costs together can exceed $250,000. Layer onto this the fact that roughly half of Americans age 65 to 74 have no retirement savings. And for those who do, paying for these costs remains daunting. The real question is, why aren't more people panicking about this and demanding policy change? And herein lies the problem. There is a major information failure. First, many people mistakenly believe that Medicare or even their private health insurance coverage will take care of this risk. They are mistaken. Medicare and private health insurance do not pay for much long-term services and supports. Second, the vast majority of people underestimate the probability that they will ever need care, and they greatly underestimate how much it costs in the community. So with all of this information about risks, costs, and current coverage like Medicare, it's not surprising that people have not done more planning for this risk. And for those who have thought about it and considered private long-term care insurance, many no longer see this option within their financial reach. For many years, there was a widespread belief that the private insurance market could play a meaningful role in addressing the nation's challenge. However, market penetration still has been fairly limited. As of 2020, there were roughly 7 million policies in force. The costs of policies have been increasing, and now we have a situation where less than 1/3 of new buyers are drawn from the broad middle class. Moreover, all major determinants of pricing and profitability for long-term care insurance companies have gone in the wrong direction. As a result, over the last few decades, there's been a major exodus of long-term care insurers from the market, and the market is shrinking rather than growing. So the upshot is that those who can't rely on the social safety net because their incomes are too high are in a situation where the money they do have cannot pay for all of the care they may need, and they don't have affordable insurance options available to them. Like Sarita says, these folks are often called the forgotten middle. It makes it very difficult to age in place, even for those who have budgeted carefully throughout their working lives. they can still end up impoverished should they need significant amounts of care.
Thank you, Dr. Cohen. Now that we have a better understanding of some of those barriers to care for individuals across income levels, let's talk policy solutions. This next question is for Pam. In BPC's new report, BPC recommends creating a standard for full integration of care for dual eligible beneficiaries. Why is it important to have a standard definition of full integration? And what should full integration look like?
Well, first of all, it's really important because the term integration is so broad and it's widely used in so many different ways to describe an assortment of levels of financial, clinical, and operational administration inside and outside of healthcare settings. Just as Bill was remarking at the beginning of his remarks about United buying the big healthcare in-home care setting, that's a form of integration. But Medicare and Medicaid integrated programs have evolved over many, many years, and they vary widely between states, between plan types, and often without a lot of regulatory clarity. So that's left us with different versions and levels of integration to the point that it can be really hard to know what we mean when using the term. So for example, having a plan participating in both Medicare and Medicaid is really critical. And without that fundamental element, it's hard to achieve meaningful integration of care delivery or to simplify beneficiary experience. But simply merging the financing under one entity is also not sufficient unless clinical care and care coordination is also integrated from the experience and perspective of the beneficiary. Thankfully, this long evolution that we've had has led to a lot of consensus among stakeholders on what core principles and elements should ideally be present for designation of a fully integrated program. And BPC has incorporated them into 6 main components in this report. First of all, fully aligned benefits and financing through a single plan or provider organization. It could be also something like the Washington State model that's responsible for providing all covered benefit Medicare and Medicaid services within the service area. So that needs to be there. Somebody needs to be in charge of the whole thing, and it needs to be comprehensive. Then one benefit package that includes all Medicare and Medicaid services, including the medical benefits, the behavioral health, dental, and long-term services and supports. And then a single enrollment period, a single set of member materials, a single point of access for enrollees to direct questions and coverage decision, and a single grievance and appeals process to streamline this for enrollees. A process that ensures that beneficiaries are informed and understand their options and rights within an integrated program, and with time to allow them to make decisions about enrollment and strong safeguards that protect the beneficiary rights. Then there needs to be a process for identifying high-risk enrollees with prompt assessment and interdisciplinary care teams and standardized assessments to develop person-centered care plans that are designed to meet the needs of high-risk and high needs enrollees, and that has to be updated over time and settings. And then a single streamlined set of measures, and this is really important because we're in measure drought and measure flood, both many times in these programs. It needs to be across the 2 programs with quality and performance measures that are designed for these complex populations and can be used for quality improvement and for beneficiary decision making. So while even in some of the most integrated programs, it might not be possible for all of these goals to be met 100%, given the differences between states and entities that would be managing. This is a good consensus for a foundation for fully integrated programs and what we mean by that.
Thanks for highlighting those important features of a standard definition of full integration. Pam, BPC also recommends guaranteeing access to fully integrated care for dual eligible beneficiaries. And to that end, the recommendations incentivize states to integrate care themselves while also establishing a federal fallback program for states that may choose not to do so. And BPC decided to include improved fully integrated DSNPs, meaning fully integrated DSNPs that incorporate some lessons learned from the Financial Alignment Initiative as one of the options for states to choose as a model of full integration. Why are fully integrated DSNPs well situated to provide integrated care to this population?
Well, first of all, Congress originally created DSNPs intending for them to integrate or coordinate care for dually eligible individuals more effectively than the standard MA plans or original Medicare program by focusing some additional care management on these high needs and complex populations. So that was their original purpose. And now where we've come to is that DSNPs are permanently authorized and available in 47 states and territory. And in 2021, we had about 3.3 million individuals enrolled. That's one of more than one of every 4 dually eligible individuals. And they were enrolled in 627 DSNPs. So these plan options are growing and the people are choosing to enroll them and they are staying in them and they're not disenrolling. Now, the FIDE SNP, fully integrated dually eligible SNP, is a subset of DSNPs. They meet additional requirements for integration, such as providing home and community-based services. And there are about 69 FIDE SNPs in operation today. But the oldest integrated plans that became the basis for FIDE SNPs have just had their 25th anniversary. So there's really long experience in working with that model. And now there's another new category of 220 approved highly integrated DSNPs. They're not quite as fully integrated as the FIDE SNPs, but they're operating in 18 states, and they can be used as stepping stones to FIDE status as well. So it's true that many of these DSNPs are far from FIDE SNP integration status, but that's often because states lack the resources and need more support to move toward integration. But the DSNP's widespread availability and enrollment growth now has created the potential to be a scalable and expanding platform for promoting more FIDE SNPs and moving toward higher levels of integration. And we also have the 10 years of experience with Medicare Medicaid plans called MMPs, and CMS recently released the new Medicare Rule changes, which propose to incorporate learning and features from the MMPs into FIDE SNPs. And that brings the BPPC proposal for enhanced FIDE SNPs closer to fruition. And in that proposed rule, CMS also signaled kind of a renewed, maybe long-term commitment to integration through the DSNP platform, noting that it avoids the burden and time limits of demonstrations, though the demonstrations have all been very valuable as well and maybe will still be around. They also cited evolving changes and standards for DSNPs, including more flexibility to provide supplemental benefits addressing long-term services and supports. It could be useful to states and to members, and their new unified grievance and appeals process. And these are positives for continuing integration through the DSNP model. Unlike Medicare Advantage plans, SNPs also have to have extensive models of care tailored to the population they enroll and audited by NCQA. And in the new Medicare Rule, CMS also cited positive results for long-standing FIDE SNPs for their care management, such as a study in Minnesota, which showed higher access to LTSS, long-term services, and primary care and lower hospitalizations and lower emergency department use. And then a study in Oregon indicating higher improvements in care for enrollees in aligned plans. So this rule also encourages states to work with DSNPs to align care coordination efforts across Medicare and Medicaid. And just a couple more quick points. I think we're very fortunate there are new initiatives from foundations such as SCAN and Arnold Ventures that are investing in technical assistance that states so badly need to help them work towards integrated models, including a Washington type of model. And finally, the MACPAC has just recently adopted recommendations that all states submit a Medicare Medicaid integration strategy to CMS and request Congress to provide additional funding to support states in developing their plans, as does this BPC proposal. So I think we're in a place where there's somewhat a convergence of thinking and activity that indicates the time is really right to push forward and build on this longstanding and growing investment by states and plans in the FIDE SNP and MMP models, and to provide CMS with the funds to support states and the enhanced authority they need to improve access to more fully integrated programs as requested and as promoted in this BCP report.
Very true. Great points, Pam. Now, before we move to the next speaker, I just want to remind the audience that we encourage all of our viewers to submit their own questions throughout this panel discussion using live chat on YouTube or on Twitter using hashtag BPC Live. We will take audience questions near the end of the panel. So next, I want to talk about what integrated care means for beneficiaries. And this next question is for Henry. Currently, dual eligible beneficiaries in 14 states lack access to integrated care. From the beneficiary perspective, would you please talk about why expanding and guaranteeing access to fully integrated care nationwide is important?
Sure, thanks, Lisa. First, I think we need to recognize that people with complex needs really can benefit from integrated care that brings together comprehensively the physical and behavioral health services, along with the community-based services and supports that people with complex needs need to live in the community. You know, to put that in a more tangible manner, I think let's look at a beneficiary living with complex needs and kind of the challenges they might face. Going to a primary care doctor to get some diagnosis and a referral to a specialist doesn't really ensure care coordination. Having specialists coordinate across disciplines is really an unlikely occurrence, and it requires a level of case management that isn't available in a typical fee-for-service environment, and even in plans where they're offering some very modest care coordination. Layer on top of that pharmacy needs, access and managing home and community-based services, and you're really looking at a pretty significant undertaking. And having a beneficiary kind of in charge of that process is not a recipe for great outcomes, particularly if they aren't doing well and their complex needs need additional management. Another factor that I think we're only now beginning to grapple with in our service delivery system is the social determinants, and what role can our integrated care plans start to play in making sure that people have access to transportation, that their housing issues are being addressed, say there might be some pest mitigation that needs to occur. All of this stuff would be coordinated through an integrated care plan. That's something that really could benefit a population that is dealing with kind of multiple chronic conditions and trying to lead a life in the community. And just to underscore this, really integrated care is a work in progress. We're creating plans that truly offer a comprehensive scope of healthcare needs. I think Bill pointed that out with United Healthcare's acquisition. And Pam just made the case about states moving through different authorities to integrate care. We're on the way, and we need to keep going forward because beneficiaries really do need better options to choose integrated care when they have these complex needs. I think the real challenge here is getting beneficiaries to the point where they can recognize and identify the value that these plans have to offer so that they will actually seek enrollment and stay enrolled.
Very true. Thanks for highlighting the importance of integrated care for the beneficiary. And we talked a few minutes ago also about the importance of Hcbs, as well as some of the administrative challenges in providing those services. Now, Henry, BPC's report recommends simplifying and streamlining Medicaid authorities, including authorities for Hcbs, as well as for Medicaid buy-in programs for workers with disabilities. How could simplifying and streamlining Medicaid authorities improve the beneficiary experience in accessing services?
Well, when B gave the state perspective, I think it made very clear that the states are managing quite a bit in terms of what the Medicaid program has to offer in terms of Hcbs. Now put yourself on the beneficiary side. Really what can result from this kind of menu of Hcbs offerings is that states will have different financial and functional eligibility for HCBS programs. And those may vary across the populations that I mentioned earlier. People with intellectual disabilities, older adults, people with physical disabilities, people dealing with mental health issues or substance use. These differences in financial and functional eligibility ultimately result in real disparities across these populations. So creating an authority that allows states to streamline and simplify moves us closer towards bringing greater equity across these populations that I've mentioned. And of course, hopefully helps the state drive these services into the marginalized communities where these services are needed the most. Ultimately, having a simplified and streamlined HCBS authority would be easier for the state to communicate when and how people can get the services and supports they need to live in the community.
Henry, and how could more federal guidance for states on Medicaid buy-in programs for workers with disabilities help to improve access to these programs for beneficiaries?
Sure, just to level set, the Medicaid buy-in program is really an eligibility pathway that allows disabled people that meet the stringent Social Security definition of disability and need HCBS to work, continue to receive Medicaid. As you know, HCBS is not offered in other forms of health insurance. And so Medicaid is really the only place where this population has to go to seek these services. And so the Medicaid buy-in really allows the individual to enroll in an eligibility group that has different income and asset limits that are set by the state. Now, the challenge here is that we have quite a bit of experience and history with this, and state variation is still there, and participation is relatively low, and largely because the income and asset levels don't really correspond with people's aspirations. So CMS should really issue guidance to states on how to use the existing eligibility groups so that people can continue to work and receive the Medicaid services that they need. An important feature here is that most of these programs are age limited. And so if you're over age 65, you're not able to participate in many states. That doesn't have to be the case. And there are many older people with disabilities that are working and need to continue. Let's remember the age of retirement now for Social Security is 66 and almost 67. So we need to sync these up and make sure that people can participate in these programs. Ultimately, the guidance really needs to show states just how they can use the flexibility in the Medicaid program to set income and asset disregards that allow people to earn a decent income, save money, buy a home, raise a family, just like every other American. And finally, I would suggest that CMS take a look at the comments that it receives. They currently have a request for information out on the Medicaid and CHIP program. I assume that they'll receive comments related to the Medicaid buy-in, and there may be a real need to codify some of these changes in regulation. So as the BPC report says, we'd urge the agency to undertake the rulemaking process and make it more clear to states about how the Medicaid buy-in can work for them and the people they serve.
Thanks, Henry. Now that we've heard about how simplifying and streamlining various Medicaid authorities and providing guidance would really help beneficiaries and improve access to these services, let's talk about the impact of states. So this next question is for B. How could streamlining and simplifying Medicaid HCBS authorities into a consolidated state plan amendment, one which retains much of the flexibilities of existing authorities while still providing budget predictability for HCBS, how could that reduce administrative burden and complexity for Washington and other states that currently rely on such a patchwork of HCBS waivers and state plan amendments?
You know, the BBC has made several recommendations around the streamlining and simplifying of authorities that really would result in a much more human-centered approach to system design and make services more easy to navigate by individuals that need them, the case managers and options counselors who assist them, and the staff at the state levels that administer and oversee these programs. If we could adopt some of those recommendations, one of which is grandfathering individuals that are currently being served into a new consolidated authority, it would alleviate a lot of concerns states and advocates have about adverse or unintended consequences of a major system redesign, which is what this would be. The recommendations also would provide ensure the budget predictability that I talked about before by allowing a pre-approved delineation of needs-based criteria and a method that could be adopted if the number of people accessing services surpasses caseload projections, which would allow much more nimble responses by states. In addition, adjustments to services and packages could be also done more quickly than they're done today. And that's important because the needs of populations served are changing. And we're learning more every day about the importance of social determinants of health and offering critical services such as supportive housing, supported employment, nutrition, and transportation to broader populations. And as states rebalance away from an over-reliance on institutional care, the needs of populations served in the community do become more complex. And there's a need to continue to develop services and provider types to support them. And we need that flexibility of a more nimble authority. The recommendations also support the ability to create varying levels and types of services and target those services to particular populations without creating an entitlement to the highest service level for every person served in that authority. This is consistent with where we have been focused on in Medicaid, which is let's provide the right level of service at the right time to the right person, while making sure that we're able to serve the highest number of people possible within our budget appropriations. Also, a recommendation in the report is delinking eligibility or needs-based criteria and allowing a lower level of need for individuals to access home and community-based care and a higher level of need or eligibility for institutional care. This is a change that states have been advocating for many years. It supports creating small benefit packages that are preventative in nature to help people delay and divert the need for more costly, intensive services, and goes a long way towards breaking the institutional bias in Medicaid for Hcbs. We also could find ways to more effectively pay for needed transitional services that really assist people and set them up for success as they move from an institution back to a community, because that would not be viewed as duplicative in the same way as they are today when we use multiple authorities. And most importantly, the streamlining and simplification strategies recommended in the BBC report will free up state administrative staff to focus on key issues that improve access, such as provider network development, outreach and education about available services, measuring quality and outcomes and beneficiary experience. This will result in easier access and navigation for those that need the service, and also free up care managers and options counselors to do person-centered work with beneficiaries rather than waste time on administratively focused complexities that really aren't designed to focus on the people that we're trying to serve.
In the interest of time, I'll just ask you to touch on this next question really briefly. If a consolidated law were to be enacted, what kind of guidance or technical assistance would states need to implement it successfully?
It's a major systems change, and with all the different authorities out there, states have a lot of expertise in how to manage that. So we would need guidance, training, technical assistance. We would need strong project management and change management strategies to ensure smooth transitions for clients, for case managers, for state staff. And I would also say that we'd want to make sure that CMS has the level of staffing and technical assistance that would be needed by states to take full advantage of the reforms. And the enhanced match recommended by BBC is also important to ensure that states have the staffing and the infrastructure needed to ensure that they can take up a new authority and create more flexible, responsive, high quality services for the people we're trying to meet the needs of.
Very true, great point. So we talked earlier about some of the challenges individuals often experience in accessing LTSS when they are ineligible for Medicaid. So this next question is for Dr. Cohen. How could policies like simplified private long-term care insurance options and employers auto-enrolling certain employees into those policies with an opt-out help to make private long-term care insurance in that market more affordable for middle and higher income individuals, as well as more sustainable for carriers?
Thanks, Lisa. You know, the affordability of policies is undoubtedly the biggest barrier to greater penetration among middle income individuals. And underlying the BPC recommendations is the desire to reduce policy costs in a variety of ways, including finding new ways to fund policies, implementing strategies to reduce selling costs through changes in the choice architecture facing consumers, and through supportive product designs that are designed to enhance the value proposition of the insurance and simplify decision-making. For example, the concept of retirement long-term care insurance put forward by BPC is designed to strike a balance between affordability and coverage by recommending that Congress remove statutory and regulatory barriers to allow lower cost, more standardized limited benefit plans. So these plans would have premiums start out low at younger ages and then grow annually and become fixed at, say, age 75. A lot of reasons why this would be attractive to consumers and insurers. First, it makes insurance very affordable during an individual's working years. And it actually makes the insurance more of a mainstream product by having people get in the habit of paying premiums throughout their lifetime. Second, by limiting certain design choices, it simplifies the product without sacrificing value. And it reduces confusion among consumers, which is one of the reasons people stay away from the insurance and selling costs are high. Frankly, it helps to move the product away from one that has to be sold to one that is more enthusiastically bought. Third, from the insurance company perspective, they would no longer have to take bets about what interest rates are going to be 20 or 30 years into the future, but instead could reevaluate pricing assumptions more regularly. And this takes a great deal of uncertainty about how insurance departments will respond to rate increase requests, something which has kept companies out of the market. It provides more certainty to carriers that they will generate the returns necessary to attract capital to this product and would likely incent more of them to enter the market. Now, BPC has additional recommended ways to reduce selling costs. First is to provide incentives to auto-enroll employees who meet certain retirement savings thresholds so that they have to opt out of a policy if they don't want it. And second is to allow penalty-free withdrawal from retirement savings accounts to cover retirement long-term care insurance premiums. Both of these proposals would likely encourage market growth. There's ample evidence from the behavioral economics literature that changing the choice architecture to auto-enrollment opt-out approaches leads to major impacts positive on enrollment rates. Also, having this occur in a group setting significantly reduces selling costs due to economies of scale. And it would also give consumers more confidence in the product because it would be part of a larger benefits portfolio put together by a trusted source, their employer. And by expanding the risk pool in the context of auto-enrollment, carriers will face less adverse selection, and the need for strict underwriting, along with associated costs, would be somewhat diminished. It also provides upselling opportunities to employers. And clearly the penalty-free withdrawal from defined contribution retirement plans, here the idea is to encourage take-up rates at younger ages and make premiums more affordable for middle-income folks. Given that LTSS needs are a major threat to retirement security, individuals should be able to use their retirement savings to meet this threat. Finally, it's worth noting that important signaling effect that this would have. Through the tax code, basically the government would be signaling that this is a product worth considering. And this will help change tastes for the product, leading to increased consumer confidence and greater demand.
Dr. Cohen, let's talk about one interesting newer type of long-term care insurance product. CPC's recommendations encourage the National Association of Insurance Commissioners to modify model laws and regulations to accommodate conversion long-term care insurance products. Could you please talk about what conversion long-term care insurance is and some of the advantages of this innovative model?
Sure. Basically, think of it as a term life insurance policy that converts into a long-term care insurance coverage at the same premium level when somebody reaches the policy conversion age. This would be very attractive for the market, and it's what Minnesota is in the process of examining right now. Think of it this way, because long-term care coverage would be linked to a product that most consumers already understand and are comfortable with, term life insurance, this would simplify the decision-making process. Also, premiums would be more in line with what middle-income individuals can afford and are also more likely to remain stable and eliminate the need for underwriting at older ages. From the carrier perspective, there are economies in selling costs. Frankly, it's like having twins, one decision point resulting in two products over a lifetime. And finally, it encourages planning by changing the choice architecture so that someone will need to opt out of the coverage at the time of conversion after they've already been paying premiums for many years. This will enhance the integrity of the risk pool and keep policies affordable for consumers and attractive for carriers. All told, the recommendations are designed to increase the value in policies by making them less attractive and less costly and more attractive to consumers, while at the same time making market conditions more attractive for carriers to enter, develop, and provide new policies.
Thank you. In these last few minutes, let's turn to an audience question. This question is, what role do community health workers play in providing this necessary care, and how would figuring out how to pay quality wages help with the sustainability and the quality of care? And I'll open this up to whoever would love to jump in on this.
It's Henry, and I can just jump in and suggest that, yes, I think there is a need for community health workers that can play a role on the ground, helping people in their homes and communities better manage some of the complex care needs that we've discussed here today. How they get paid and how to justify the rates, I think, is an exercise that the federal government is engaged in right now. I referenced an RFI that CMS has out, and indeed there are a set of 5 questions. One of them really leans into how to better pay the direct care workforce, which I would include these community health workers in.
Great point. So in this last minute, I just want to say a big thank you to each of our panelists, to all of our viewers out there, and especially to the SCAN Foundation for their generous support of this event and this report. If any of today's topics piqued your interest, please check out BPC's website for our new report titled An Updated Policy Roadmap, Improving Care for Those with Complex Needs. Thanks again, and take care, everyone.